So it's my absolute pleasure to welcome Dr. Ruth Zitnik from Youngstown, Ohio, here to speak to us today. She is an educator. She is the superintendent of schools at Maysville in Youngstown, and she has done her research in the effects of implicit bias in urban schools. This is a very hot topic. Faculty will remember last year we read Blind Spot and have discussed that. Implicit bias affects all of us all the time, but particularly here where we consider ourselves not just doctors, but educators, this is an incredibly important topic for us to hear about. So thank you for making the trip out here, Dr. Zitnik.
Thank you. Okay, good morning. So it's great to be here today. I feel very humbled and honored to get to share a little bit of time with you. Typically, when I do these types of presentations, they take much longer than the typical 50 minutes here. So we're going to probably race through some things, but I am going to try to give you an in-depth but broad overview about implicit bias. And so since most of my presentations have been with educators and the business community, I've tried to tailor some things specifically to medicine so that it will be meaningful to you. So I want to start by asking you, see if this will, it's all right, it just may be that I have to move up. There we go, I got it. Okay, so I put out some Post-it notes. So you're going to see I'm a teacher. So number one, sitting in the back is not going to protect you from me because I move around. Because in a classroom, how effective would I be if I stand at the front and I don't interact with students, and in this case, participants? So I'd like you to take 1 minute, and there's Post-it notes that if you would just grab one and write down everything you can think about when I say implicit bias. What does that mean to you? So just want to take 1 minute. We have about 10 seconds. Okay, now, who's brave enough to share something about what you think about when you think about implicit bias? Is there any brave soul in here? Gone through medical school, but not real brave. Yes.
So I wrote down that it's commonly unconscious, and when you're faced with it, you may even find yourself denying it. That sometimes it can be internalized by a group against bias against themselves, and it can be institutionalized in larger institutions.
Great, and you've read Blind Spot too. Okay, yes?
Not fully aware of assumptions made not based on fact or experience, but on leaps of judgment.
Great. Anything else? Anybody from this part of the room? Come on, there's got to be a brave soul. Nobody's brave? Yes.
Like pervasive thoughts, preconceived notions that are kind of unrecognized and kind of a long denial, but or uncomfortable.
Okay, absolutely. So it seems like we have a basic understanding of what we're talking about when we reference implicit bias. One thing it is deep in the subconscious. So it's not something that through introspection you can figure it out because it's really down deep. It's, and those of you that have read Blind Spot, you know they talk about the authors really delve into how it is in those hidden places in your mind and how there are mind bugs and just kind of tricks you, right? So it affects understanding. I don't care if you're in a classroom or if you're working with a patient, it's going to affect your understanding. It affects our actions, and we don't even realize it. So sometimes you'll look at a person and you'll say, I don't understand why they did that. Well, it's possible they don't even understand. It definitely affects our decisions. And when we talk about stereotypes, what happens in implicit bias is this is a rapid socialization that happens to us. When we are little, you're dealing with little 3-, 4-year-olds. It starts embedding itself into the mind and into the mindsets, and it's tied to their experiences. I experience something, therefore I connect something to it, and therefore I think that all doctors are terrible because they give shots. Okay, so those are pervasive things that may last over long periods of time. It's a social conditioning that causes us to form judgments. The most interesting thing about it is that it predicts how we're going to behave. Isn't that scary? Something that we don't even recognize within ourselves can predict how we're going to behave in certain situations. That it's the implicit biases that we hold affect our attitudes without a doubt. It's involuntary. It's not something that I wake up today and I decide I'm going to make an off-the-cuff racist comment. What happens is people make comments that they don't even understand. So they'll say, well, I'm not racist. I have lots of, African-American friends, or I have lots of Indian friends, or whatever it might be. That in and of itself indicates that a person is not in touch with what their implicit bias actually manifests as. It's not, like I said, you can't get to it through introspection. That's not how it's going to happen. And it develops through these continued exposures and indirect messages. But here's the best part. It can be unlearned. But there have to be specific strategies that you use. And today we're going to talk about that. What would be some debiasing strategies or techniques that you can engage in? So the first part of this is about helping you to understand why it's important to look at this, especially in the medical field. So we go back to 2018 in April. And as you recall, there were two gentlemen, and I have to look at their names, Dante Robinson and Rashawn Nelson. So they go into Starbucks, and they sit down, and they're getting ready for a meeting. One of them goes up and asks to use the restroom. Everybody heard about this situation. It was pretty national news. They were arrested, right? So why does that matter to us? The reason it matters is because you had a manager there with an implicit bias that manifested in a really bad way. And not only did it manifest in a very negative way, it had outreaching effects across the nation. There was outrage, there was anger, there was all this just disbelief that this could happen. But yet, how many of us could look inside ourselves and would find that we have biases that we don't recognize? So we make an assumption. I'm walking down the street and dealing in the urban school, being a little tiny kind of white blonde woman principal in a high school, in an urban high school, where I have gangs and I have black males who are already marginalized, dealing with things on the streets that I can't begin to imagine or understand. And so I have to check my implicit bias, because guess what? Some of those kids I deal with right now, they're in prison for murder. They're in prison for, rape, for many different things. So going back and putting myself into check and saying, because these behaviors happen with some black males, that does not mean that every black male in my school can be connected to that, all right? But there are a lot of people in my research. What bothered me the most is how many teachers didn't even realize that they had those mind bugs in their head. They had these thoughts and stereotypes that they did not even recognize. So why does this matter? If you remember, the CEO decided, okay, we're going to take 175,000 employees and we are going to put them through training. We're going to close over 8,000 stores, and for 4 hours, we're going to put them through training, and guess what? We solved the problem, okay? That really was their thought process. What's critical to know is you can't solve the problem by going through and having some training. So what I want you to do right now I've set some quizzes. So these quizzes right here, if you'd pass them down, make sure everybody has one. I told you, we're going to do a little bit of activity here. I pray have. Oh, we got one. Okay. So I'm going to ask you to take a few minutes and just go through. So Stratus Health put out this brief questionnaire, I guess, quiz. So I want you to go through it and quickly read and just mark your answers. You're not going to get graded, I promise. You don't have to turn them in, so. Okay, it seems like most people have kind of gone through this, so let's just take a minute to consider the responses to the questions. So in the first one, microaggressions, okay, these slight snubs, these small things that send a message every time that you speak or act. So which of the following is an example of ethnicity-related microaggressions in a healthcare professional? So what would be the answer? All of the above. So in your role, it's important to be aware of subtle forms of discrimination because it can absolutely undermine patient-centered care if you're not aware of that. Okay, how about number 2? True or false? True. So the University of Pittsburgh and the School of Medicine, the physicians displayed different nonverbal behaviors with Black patients. And it was the same treatment that they gave to the patients, but their way of interacting was different. So guess what? Even though the treatment plans were the same, the outcomes were different because of the response from the patient. So these implicit biases that come out in behaviors affect how patients are going to react to a doctor. Number 3. What's the answer to number 3? Okay. Okay. The answer is C. The reason C is the answer is because it's a macroaggression. Okay? That's something not only is it unethical, and no one better do that, but it's really a very biased attitude for someone to have. But understand, coming into the medical profession, there are people that believe this. That's astounding, but it's true. And so understanding that, even as a professional in your field, helping other people to come to an understanding of their implicit bias is your responsibility as well. And research has shown, especially with physicians, and I'm just talking research, this isn't Ruth's opinion, but because oftentimes doctors are so highly educated, it's harder to recognize those biases because sometimes, and I can attest to that in myself, I've had a lot of schooling, probably as many years as you have. And let me tell you, there are times when I still have to go back and recognize, wait a minute, that's coming from a place that's not, as someone over here said, based in fact. It's coming from preconceived ideas and stereotypes that have been enfleshed in me that I have to make sure that I get out, okay? How about number 4? All of the above. So here's the interesting idea behind this. These can be good intentioned, but they send the wrong message with disabled individuals because what it says is you can't do it. I deal with this in schools all the time. That's why students with disabilities who are labeled Ed typically struggle because of teacher perceptions and teachers' expectations. Well, they can't do it. It's the same thing in the health field. Making sure that you're not putting those beliefs onto people that you are, interacting with and the patients that you're working with. So number 5, what's number 5? All of the above. Very good. You're getting an A+. Okay, so this impact toward bias toward non-white patients compared to white patients can result in disparities in health care. Many studies show that Black males are prescribed less pain medication, Where does that come from? It emanates from an implicit bias that we may not recognize that we have. Also, research has shown that black males are less likely to be aggressively treated for heart disease. I mean, those are astounding studies to think about, okay? And the first thing that probably rises in your mind, well, that wouldn't be me. That wouldn't be me. But remember, this is something that's so unconscious, you don't know if it would be you. So it's your responsibility to find out if it's you and to find out how you combat that. Number 6. All of the above. So it's reciprocal. Clinician behavior and decisions affect the patient behavior and decisions. I can just share a quick story of a very dear friend who, her husband is an elderly man, went into the hospital down in Florida and really wasn't treated, she felt, in the way that he should have been. And her response to me is, those doctors don't care. He's old. Everything they tell me is that, well, that's his age. That's what's going to happen. But what we can never forget is that individual matters to her, okay? And that might even be the case of what you need to say. But words matter, and we're going to talk about that in a minute, and how you convey information and how you take your bias out of it so that it's evidence-based. We're on number 7. All of the above, okay. So a 2014 study suggested 80% of the time that a patient felt a stigma of poverty, it was a direct result of the intervention with the provider. That might be a nurse, it might be an intake person, it might be a physician. But when they had to say that they were on Medicare, or they had to say that they didn't have insurance, and you know, a lot of nonverbals, a lot of comments that might come back affect how that patient then responds. Number 9, all of the above. And research also shows that sometimes doctors might be on the defensive when they're dealing with people who are older, especially if it's not your field of typical practice. So a person comes in who is more aged into the emergency room. Oftentimes, I shouldn't say oftentimes, but studies have showed that sometimes doctors start out on the defensive because they don't want to be viewed as if they're not taking those complaints, I guess, seriously. And number 10. All of the above. Okay, and we're going to talk a little bit more about number 10 in just a little bit. But first of all, now if you read the book, you've already heard this, so you have an unfair advantage. If you did not read the book, think about this. So, and you may have heard this, but it proves a point, or demonstrates a point, illustrates a point. A father and a son were involved in a car accident. The father was killed and the son was seriously injured. Father was pronounced dead at the scene of the accident and his body was taken to a local morgue. The son was taken by ambulance to a nearby hospital and was immediately wheeled into an emergency operating room, and a surgeon was called. Upon arrival and seeing the patient, the attending surgeon exclaimed, "Oh my God, it's my son." Can you explain that?
Surgeons.
Very good. And I figured in this room that might come out, that the surgeon is the son's mother. But do you know what? If I do this in a room of educators, hardly anyone ever gets it, if anyone. Because almost half of the population, when given this scenario, automatically goes to, it's a man. Because these are deep-rooted ideas that we have. Now, when you're in the profession, you become aware that that's not necessarily true. Yes?
I suppose the other answer could be that it's a man and it's a couple.
It could be as well. It could be as well, but even more ironically, nobody ever thinks of that. Seriously, nobody ever does in my presentations, except for here. So today's a A new day. But you're absolutely right. And our thinking does cloud how we reason. And remember, too, it's automatic. It's quick. It happens without us even realizing it. So when that occurs, we tend to get sometimes off kilter. So the next thing we're going to do, you're going to have to get out of your seats. Sorry. But you see these, there's shapes and colors. Everyone needs to have a shape or a color. So we'll just pass these down. Doesn't matter what shape, doesn't matter what color, just so long as everyone has one. There you go. There you are. You're welcome. Okay. Does anybody else need? I have kind of set around. Do we have people who do not have shapes and colors? I thought so. I think we should have extras, don't we? I have 75. Thank you. Thank you. There you go. There you go. I go to the people who most don't want one. Just kidding. I'm kidding. You have to understand, I've been a teacher for years. Okay. All right. So I apologize if you don't have one. But for those of you that do, what I'm going to ask you to do is to form groups of 6 without talking. Just get up, form groups of 6. I know, you're out of your comfort zone, aren't you? I know. So hold your card up. Hold your card up so everyone can see it, and form groups of 6. Okay? Now I'm going to ask you to form another group of 6 with different people, and then you're going to tell me why you formed that group. So no talking, form groups of 6 people. It's all right if it's... Okay. So what's your rationale, even though we don't care if there's more people or less people. Okay, so what's your rationale for forming this group right here?
It was close.
It was close.
Geography.
Okay, how about here?
We affiliated because we were close, physically.
Physically close to each other. Okay, how about here? What was your...
Because we like each other.
You were yellow. Okay, how about over here? Why did you form your group?
They needed 2 more people.
Okay, how about here? Purple. How about over here? Closest? Yellow. And then other people, yeah, horned in. Okay, how about here? Shape and color? No reason. Okay? What was it? Proximity. Okay. Go ahead and take a seat.
That's 678 people. It's a wonderful.
Oh, the Irish.
That's all right. I'm going to help.
The exercise was we went by convenience. We found 5
That's all right, though.
people and said, here's a hole here on the fill.
That's okay. So, what does this have to do with implicit bias? I'm going to tell you. Number 1, we are most likely to go with people who we work with or we're closest with, that we have some affinity to, that we can connect with, that we are the same. Okay, so some people did it out of convenience. It's just easier. I'm not going to think about it. All right? Other people did it because we're going to put thought to this, and we're going to do it by color. We're going to do it by shape. Because when we group as individuals, we do it unconsciously. all right? So number one, you're out of your comfort zone. You're trying to figure out what to do. You're not really allowed to talk, although I'm not going to say everybody followed that direction, but that's okay. It's all right. But when you form these groups, guess what? Every time you form a group, there are outsiders, aren't there? Whether it's your friend group, whether it's your work group, whether it's your family group, there's always going to be outsiders. And that's where implicit bias comes in, is how do we view the outsiders? And how do we change our behavior so that we change what happens with outsiders? I'm guess not moving. Okay, so when we think about recognize implicit bias, my question to you is, why would that even matter? Why is that important? Why are we talking about it? It's a very sensitive topic because it causes us to say that we have biases and that sometimes our actions aren't the way we really want them to be, okay? And sometimes they have bad outcomes, bad situations that happen because of it. What research tells us is that it affects the quality of care, and you cannot help it. Unless you do something about it, it's affecting quality of care every day in the health field. And as a patient, I can tell you I have felt this, okay? Misdiagnosis if questioning is impacted. What does this mean? So if I come in and I have somebody in there who's been in the ER 12 times, they're always coming in because they're high or living on the street, whatever. If I do not have that level of empathy and I do not put in check my implicit bias, I may decide to not ask the whole gamut of questions that we would typically ask a patient because I already know. He's coming in here, he's high, so I'm not going to bother, okay? Now, there may be some validity to things where you see repeated patients and you have a certain understanding about them. But if it is a patient, let's say, that is not somebody that comes in all the time, but does have similar characteristics to patients that come in all the time, you may make that connection without even realizing it and treat that patient in the same way that you do any other patient coming in, especially if that patient is non-white. Nonverbal actions undermine patient trust. So when I stand here and I'm talking to a patient and she's talking to me and I'm like, yeah, and I'm looking on my iPad and I'm not really maintaining eye contact, okay? Crossing my arms, things like that. It's sending messages that what you're saying may not be that important to me. Now that might just be, somebody who doesn't have really good bedside manner, but it also could be that your implicit bias is coming out because you're not seeing that patient as an individual. You're seeing that patient as maybe a group, a representative of a group, yes.
But maybe that patient isn't seeing you. You're talking about everything that we do, and this is a communication between.
Right, and we're going to get to that.
Sorry.
Yeah, no, but because you're absolutely right, it's reciprocal. It's absolutely reciprocal. And today is really about helping you to kind of look at it from your perspective, because remember, can we change the other person? No. The only thing we can impact is ourselves. But yes, the patient has responsibility in this too. And it especially happens, and I can tell you in my world of working in urban education, it particularly happens with poor Black people. There's a chip on the shoulder because of life experiences, because of things that have happened to many of these kids. Not everybody, because that's what we're talking about, breaking the stereotypes. But I can tell you many of those kids that would walk in my office, I knew they needed me to see them first as a child, and first as somebody who needs help, who needs to talk, who needs whatever, and not to put in front of that, okay, this is a kid who's gang involved, this is a kid who's a Black kid, especially in adolescence when kids get into stuff that they don't know how to get out of, okay? So when I'm talking implicit bias, this applies to me. It's not something that's just you. It's just today I'm trying to kind of share some of my insight with you, I guess. Physicians who have high levels of implicit bias are known to dominate the conversation. So there's less listening and more talking. More, I've already made up my mind, more I'm just going to tell you. And Physicians with lower levels of implicit bias tend to listen more and talk less. Okay, that's what research tells us. Physicians with higher levels of implicit bias also lower patient confidence in the physician. So words matter. In 2003, the Unequal Treatment Report from the Institute of Medical Panel said that even when controlling for access to care barriers such as insurance and so forth, ethnic minorities received worse treatment. Yes?
Is there an association with the amount of time you have in a visit and like how much your implicit bias comes out and how easily you can correct it? Like if you're short on time, you can fall on the biases more.
There is in that, because unless you're very conscious about it, the implicit bias happens automatically. And so we're going to get into the triggers that cause that to happen. And if you're aware of it, so you go in and you only have 2 minutes to be with a patient, maybe you're triaging, whatever, and you only have like 2 minutes, but I know that I have a tendency to be standoffish with this particular patient, okay, or this particular ethnicity, or this particular female, whatever it might be, then you can correct that, okay? You can make conscious decisions to intentionally change your actions. And so that's what we're going to talk about. That's why I kind of divided this. This part is just about recognizing it, understanding what it is. And then we get into what do we do about it. Implicit bias can cause the provider, like we said, not to ask critical questions. And sometimes it's not easy to capture all of this, what happens with implicit bias, because it is unconscious. It's not something that's out there that we can easily measure. So when we talk about words matter, what research shows is people in power. This is not just doctors or, you know, it's me. I know it's me, and I have to check this. But people in power tend to use verbiage to maintain the control and the power. So if I have an irate parent that's coming into me, I know this about myself. So I'll have a parent that causes trouble all the time, wants to come in and complain about my staff. Okay, I know how I can put that person in their place. I just start using my jargon, and guess what? They're like, I don't even know what this woman's talking about, right? So because I know that, here's what I always do. I bring the person in, I sit next to them. I don't sit at my desk. I put chairs beside each other and I talk to them. And I say, I know you're concerned. I know you're upset. I can see it from your, demeanor. So talk to me. Talk to me about what you're upset about. Talk to me about what happened. Explain to me, how you felt so-and-so didn't handle this correctly. See how different that is than if they come in and I start on the defensive and I start saying, my staff is trained and my staff this and my staff that. It's a very different approach. So myself, I've had to learn to do that because I am, in my district, I'm the most powerful person. I mean, I just say who stays, I say who goes, I say where kids get educated, I say what, where we spend our money. I mean, I have control of it all. And I always used to say, I don't have to tell people I'm the boss because I am. So my mentality has to be, but I am a servant. I am a servant leader. I am not there to be the boss. I'm not there to just be the expert. And I can't be the expert with every child. That parent has to help me understand their child so that we can make the best decisions. But it's easy to fall into that trap of using that language and using the jargon that we are educated and we have a high volume of vocabulary. And so when we do that, it can be very off-putting, okay? And the social dominance that takes place, especially among people who are educated and who are not. So our biases are not limited to just females or ethnicities or religions or age it can be anything. So that's why it's important that we take time to look at ourselves. So social psychology theories support that idea that people in power use power language. The other thing is this just being patronizing and using words first person plural pronouns. such as, like in one literature, we're going to take our medicine, right? Okay. We're going to change our baby's diaper, right? You see how patronizing that is? But when we say that, what we're saying is, I don't think you're intelligent enough for me to speak to you as an adult. So I'm going to talk to you in a term that shows you I'm like the parent and you're like the child. But that happens all the time, and it even happens in our field. So physicians with high implicit bias tend to be less patient-centered, less supportive, spend less time with patients, have a greater proximity from the patient, and past discriminations become very exacerbated. So what do I mean by that? So when I've had situations where I have been involved in discriminatory situations, they become more and more perverse as I live in my high implicit bias and I don't put it in check. So it becomes very concerning when I'm spending time with patients. So one study showed that Black patients really picked up on these types of behaviors. And what was the outcome for them? They had difficulty remembering what the physician talked to them about. They had less confidence in the treatment plan. And they really felt like they would have difficulty following the treatment plan because there was not that connection. The negative effects, interestingly enough, these negative effects can happen within your ranks and can affect patient care. So I'll use an example from my world. So I have teachers and I have aides. But I have aides who are not as equipped as teachers to manage a classroom, let's say, because they haven't had the schooling, they haven't had the experience, they haven't had taught the strategies. But I'll have aides that right away, they just have an attitude like, that teacher thinks she's better than me. She thinks that I'm just an aide. I'm just a peon. I mean, they'll say things like that, right? Does that happen along doctors and nurses, X-ray technicians and nurses and different people? Yeah, because you have implicit bias about the people around you. And you may not even realize it. So I have a very good friend who's a nurse. And she shared with me the challenge of working with some doctors who really think they're better than them. And I said to her, I said, do you really think that this particular physician thinks he's better than you? Do you really think that? And she's like, yeah, I think that. And I said, well, what makes you think that? Well, because he just comes in and he tells me what to do and he wants this done and he wants that done. And I said, Amy, but isn't that what he's supposed to do? Isn't it his job to write the orders? Isn't it his job to decide the treatment plan? And she's like, yeah, but I've been there for 6 years now and I know what's supposed to happen. But do you see how she has this bias? The more we talked about it, the more she started to realize, you know what? Yeah, maybe he doesn't. Maybe he really doesn't think he's better than me. Maybe he's just doing his job. But guess what? A patient picks up on that. Patients can sense that. So if I'm in, for care for whatever it might be, and I'm sensing this inequity or feeling of inequity between my providers, it affects how I'm going to be focusing in on what's being said to me and what's being recommended to me and how much credence I put in that. So negative effects of high implicit bias, it can sway your treatment decisions, okay? What am I gonna decide to do? If I'm looking at somebody as a part of a stereotype, so for example, I'm a woman of advanced age, I guess. But there was a time when if I would have gone to the doctor would not have really spent much time talking about my heart, okay? Because I didn't fit into a group that would be recommended for screenings, for stress tests, for things like that. Fortunately, the research has changed and doctors know that even though I'm not like old, I'm old enough that those type of things need to be checked, even if I have no history of it, all right? Even though I may not be in a group of people that typically would be like maybe men, all right? So treatment decisions can be swayed when you're looking at things from that kind of a broad perspective instead of looking at the individual patient. Can definitely be discriminatory, and I think I've talked enough about that. Can result in treatment dropout because if patients don't feel like you're talking to them and considering their specific needs, then they're more likely to not come back to you or to maybe not go to any doctor, avoiding healthcare altogether, and delaying filling prescriptions if an attitude comes across. If I'm a person and I'm a single mom and I'm working 3 jobs and I'm tired and I bring my child in, for something, and just a comment is made to me about how I'm not really a good mother, And you're not going to say you're not a good mother. What you're going to say is, didn't you notice that your child wasn't getting enough sleep? Didn't you notice that your child threw up 3 times today? Well, no, actually I didn't, because I was at work and my child was with my sister. And I didn't find out till I came home at 10 o'clock at night. Okay, so you don't know the situations that people are in that are coming in to see you. And so sometimes that delay in filling prescription, because you know what? I'm not sure I'm even supposed to be doing this. I don't even know what I'm supposed to be doing. I'm so overwhelmed right now. And so instead of going and doing what needs to happen, I may not have the skill set to do that. And I don't trust you as a doctor because now I feel incompetent. You see how it's like a snowball effect. So when we talk in terms of patient care and organizational decision makings, let me go on to, so here's another interesting study. Non-white patients receive fewer cardiovascular interventions and renal transplants. Black women are more likely to die after breast cancer diagnosis. Non-white are less likely to be prescribed pain meds. Black men are less likely to receive chemotherapy or radiation for prostate cancer and more likely to have a testicle removed. Now, this is all in research. This is not something I'm saying, and I'm not saying it's Bay-State either. I'm just saying, in general. Patients of color are more likely to be blamed for not taking care of their own health. So when we think about that, how does it affect all of these things that we do in our daily profession? So consider, if implicit bias affects clinical judgment, behavior, if it can be found in the diagnosis, and it can be found in the number of tests ordered, then we're not going to do this just because we don't have time, but I want you to think about it. What is an implicit bias that you can recognize in yourself? Because remember, also, implicit bias is not just that you have a bias against someone in another group, another outgroup. You could have implicit bias within your own group. So think about it. What do I see in myself that I can recognize, okay, that causes me to think of a group of people in a certain way? So, I'm not going to ask you to talk about that, but all right. So we want to acknowledge that there are ways to uncover implicit bias in ourselves. You can question your own behavior. It's just not through introspection. You have to look at the behavior and say, what causes that to manifest? Personal unconscious bias, experiences that influence our mindsets. We've talked about that. These ingrained stereotypes. One of my professors used to say, I'm fleshed. From the time I was a little girl, my parents taught me, you know what? Black people are not as good as white people. I was taught that as a child. My grandmother's house was broken into. She was attacked and brutally beaten by 2 black men. So guess what? By the time I was 16 years old, I really thought that. I really did. And I think that's part of what spurs on my study of this, because I knew that that was, eventually what happened. I ended up going to school with black people. I ended up having black people as friends. And I started realizing we're more alike than we are different. And those differences actually enrich my life. So even though it was enfleshed in me from a very young age, I had to recognize that I had that bias not because of something that I believed. And what happened, there became a cognitive dissonance between what I believed and what my bias was. So I had to actively engage in ways to change that. And that's what we're going to talk about. How can we do that? I'm going to move through this a little bit quickly. First of all, not underestimating the impact that it has, because it does. And as an educator, if I have a bias against a group of people in my school, it's going to affect the decisions that I make. So we process social information. It's automatic, unconscious, it's emotionally driven, and controlled thought and conscious reflection. So what do I mean by that? We actually process information by two routes. One is where we talk about it. It's automatic. It's emotionally driven. I was raised that way. That's what I think. The other way is where we really control our thought and we have conscious reflection and we start to equate, is it true? Are there facts to back up the way that I think? And if there are not, what am I going to do to change that? So we have to really understand that even though we try to align those behaviors the way that they would align with our values and our beliefs, prejudice resists change. It's hard to change that because it's become a part of you, of who you are. So inconsistency in our values and our biased responses occur. We start just coming out with these natural tendencies. So especially for physicians, there's triggers that you need to be aware of. One is fatigue. So you work long hours, you deal with a lot of stuff. So when you're more tired, you're more likely to go back to or revert to the implicit biases that you have. Sensory overload. You have 12 patients, you're trying to figure out what's going on all at once. Frustration, can't figure it out. I don't know what's wrong with this, child. I don't know what's wrong with this adult. I don't know. Cognitive overload. You're really dealing with a lot of information, okay? And for residents, you're studying, you're preparing for the next level, you're constantly learning. Plus you have this huge patient load. Plus you're working all these hours, right? So you tend to go back into that just natural, automatic response and emotionally depleted. And I've got to believe it happens to me. I know it happens with you. And even if you are a physician who's been in the business a long time, sometimes you get patients that it just takes everything out of you. Maybe you're not giving them good news. And 9 times out of 10, the evidence is ambiguous. It could be this, or it could be that, or it could be that, or it could be that. So all of these things are coming at you, and when all of this is happening at once, I guarantee you, you are really, really open for high implicit bias. So, but if you know that, you can actually work to counteract it. So there are organizational interventions so that you can prevent bias from affecting the quality of care, where every point of patient contact is really met with addressing implicit bias. There's strategies, actions to increase the impact. One of the things that's pretty cool, and I know we talked about this, is that medical schools are trying to be more accepting and inclusive. All right? In the past, it wasn't very often that you saw people of different ethnicities and races and so forth necessarily coming in, if you look at the history of medicine. But that is definitely changing. Healthcare settings that minimize provider stress and fatigue, I'm not going to get into that because that's kind of an organizational decision. I don't want to cause any issues here. So interventions, though, practiced individualizing patients. So what do we mean by that? When we talk about looking at the patient as an individual and not as part of a group, looking at those specific qualities and information that that patient presents. We talk about prejudice habit breaking. So Devine and Cox contend that implicit bias, once recognized, can be overcome through experience with effort and motivation to form a new habit. So remember, you always, if you're breaking a habit, you have to fill it with something else. So you have to fill it with positive action. Perspective taking. So perspective taking refers to active contemplation of the other's psychological experiences. Thinking and imagining the feelings of that other person really is a different level of perspective taking. Emotional regulation skills. So studies show if you have stronger emotional regulation skills, then you are less likely to deal with implicit bias. Partner building skills. So you create a partnership between you and the patient. And this is kind of what you were talking about, is that you address it as, you reframe it, we're working as a team. So I'm gonna talk with you and you're gonna talk with me. And so that interaction changes the dynamic. Individuation is, again, really looking at that person individually. Making culturally appropriate attributions refers to identifying people in a culture like an exemplar and continuing to think about that person to replace these biases that you might have about a particular culture or ethnicity, or maybe it's a gender, whatever it might be. Counter stereotypic imagery ties into that same thing. So we think of women as weak and they should stay home. Instead, you continually visualizing women working in the workplace, having jobs in science and math, and definitely reflection of your own behaviors. So actions that you can actually take. Having an awareness of the patient's culture is pretty important. And I know that's hard to do, but it may involve studying the culture of patients that you typically serve, which will broaden your understanding. Really respecting that implicit bias has a huge impact, and that situations can inflate bias, such as the triggers we talked about. And broaden that diagnostic view, as opposed to just saying, well, you're a woman, you're 45 years old, therefore we're not going to even think that this could be related to heart disease. Collegiality and peer support. In helping one another when we see that or when we need help with addressing our implicit bias, including others in our groups that don't necessarily look like us and think like us and are like us. So we want to expand that. Reflect on the results when we're consciously changing our behavior. Reflect, does that really cause a change? Is something different happening? So kind of gone through these things pretty quickly. There's a whole lot more I could share with you, but we're out of time. I guess the biggest takeaway that I would like you to leave here with is that implicit bias is not a bad thing. Doesn't mean you're a bad person, doesn't mean I'm a bad person. It's just a part of being human, all right, and our brain processing information. But there are times when we revert back to those automatic thoughts and ideas. And so if we do that, we have to take action to change that. And I'm going to share this last slide with you. This is really a cool thing that I did. It's called a bias cleanse, and it came out of the Ohio State University, where you can go in and you register, and every day for, I think it was 7 days, they send you an email. And in the email, they will send you pictures and little vignettes to make you think differently about particular groups of people, okay, to help you to break stereotypes and to help you think in a broader term. So every day I would get these, and they would suggest, like, for example, you know, that women belong in the home. So they have a man feeding the baby, and then telling you, you know, to reflect on the fact that men do not typically get paternity leave, but how important is the man in the role in raising the child? Just different things like that. So I just wanted to leave that with you, that it is just one tool that you could use to work on these debiasing practices, okay? So I know we've gone quickly, and I tried to cover a lot that I usually do in about 4 hours in short time. Yes.
Hi, thank you. Thank you so much for coming. I'm going to tell you a short story, and then I want, my question is, at the end of the story, it will be obvious to you sort of, how do you, I guess, communicate to someone a peer, but particularly someone in authority, that you think that you've just observed this implicit bias. How do you share that in a way that that person can hear? So here's the story. I'm a pediatric endocrinologist. This is 20 years ago. I was on rounds with my fellow residents and medical students. We're walking back to the office, and the fellow says to me, I'm going to tell you something that you're not going to like. And I said, okay. And she said, do you realize that you never call on the women students, you only call on the men? No. I did not realize that. But obviously, I've never forgotten that story.
Yeah.
So I still know this fellow. This was 20 years ago. I think it took a lot of courage for her to do that. So my question for you is, particularly to this audience filled with residents, junior faculty, and senior faculty, how do you communicate to someone what you just observed that might be implicit bias?
You do that. First of all, what you don't do is come up and say, I think you have implicit bias. Okay, that's one thing. But really, you approach the behavior. So implicit bias manifests through behavior. So behavior you can talk about, and you can question in a way that says, so from my perspective, I would say, I noticed that you call on men much more often than women. Is there a reason for that? Is there some, because it affects me. So you can personalize it into, how does this affect me? Or when I see this, it really concerns me. And so I'm just wondering what you think about that. Because what you want is to elicit it out of the person as opposed to judgment on the person, okay? Or even judgment on the behavior. So when I go to meetings, there are only 17% of the superintendents in the state of Ohio are women. So I can go to any conference and I get right in the restroom, no line. That's the benefit. The downside is I am very sometimes offended by the things that men will say, or how they will treat me, or how I am marginalized as a woman. And it happens, believe me. So the county superintendent refers to Dr. Baker, Dr. Heyer, Ruth Zitnik, or Mrs. Zitnik.
This happens in medicine.
Okay? So all I said was, excuse me, it's Dr. Zitnik. And he was like, oh, yeah. Okay? And the room went silent. But then ever since then, that's called to attention that that wasn't okay. You know, but I kind of did it in a way that wasn't overwhelmingly judgmental, but just, I'm Dr. Zitnik, you know, so that's how I'd like to be addressed. And so when you encounter these types of things, I think the most important thing is refrain from judgment. Even if it's judgment going on here, don't let it come out here, and address the behavior. You know, and in a way, and if you can address the behavior in a way that that behavior of yours affects me, it's much more powerful than if I just say, well, I think you talked to that person in a way that made them feel bad. No, personalize it yourself. Here's why I take issue with it. This is why, you know. Any other questions? I know I went very quickly, and let me just thank you for, oh, yes.
So I'm plugged for the show Trigger Warning by Killer when I had Netflix, which addresses a lot of these things.
Yes.
And there's a one on Crips and Bloods in that series, and he reframes the term gang to say street fraternity, and like maybe we can put that in our minds, like this person is engaged in a street fraternity,
right?
That may have some upsides and as well as downsides.
Yeah. That's a great point, because that's exactly what we did. Do you know what I did? And I'll close with this. In my school, I had 2 rival street fraternities, which ironically, that is kind of the terminology we in education use, but most people think we're crazy, so I don't usually say it outside. But anyway, what I did is I brought these rival groups into my conference room, separately, not together. And we sat down and we had a discussion about school is a different place. And I said, look, you guys are all leaders in this school. Sometimes you lead by fear. Sometimes you lead by, intimidation. Not always a good thing. But what I'd like us to talk about and come to a compromise is that when you come to school, it's a different place. So let's help me establish a set of rules, a set of guidelines that we can all operate in so that we don't have you guys going at it in the school and that we can keep the focus on learning. And I'm going to tell you what, both of those groups really, really responded to that. And I can also tell you that it ended the fighting, ended it. I mean, there wasn't one here when it ended it. And so did it happen out on the street? But I can't control what happens out on the street. But because I appealed to their intellect and to their emotion, and they cared about me, I cared about them, I talked about, this is how it affects me. When you guys do this, this is what happens in our school. And so they took much greater ownership with that. And we had great success in turning around a very violent school to becoming a school where we ran an international baccalaureate program and an advanced placement program and post-secondary. So I was pretty proud of that kind of work, but it all goes into really addressing my implicit bias as a leader and then helping others to do the same. So,
Thank you.
you're welcome. Thank you. Thank you.